All right, let's jump right into it. Welcome to today's explainer, where we're going to do a rigorous, no stone unturned clinical breakdown of subdural empyema, or SDE for short. This is one of those conditions that absolutely requires immediate recognition. So by the end of this, you're going to understand exactly why it happens, how it spreads, and what you need to look out for when a patient rolls through the doors. We're breaking this down point by point today. We'll start with what subdural empyema actually is, look at the epidemiology, dive into its etiologies and origins, identify the specific causative organisms, and wrap up with the clinical presentation findings. Okay, part one. What is subdural empyema? Let's establish exactly what we're dealing with anatomically. So what is SDE? Well, historically, before 1943 or so, they called it a subdural abscess. But to be precise, subdural empyema is a suppurative, meaning pus-forming, infection, and it forms right in that space between the dura and the arachnoid membranes. Now, this definition is absolutely crucial. Why? Because this specific anatomical space completely lacks any anatomic barriers. That means the infection can just spread like wildfire freely over the convexity of the brain, dive straight into the inner hemispheric fissure, and sometimes even cross over to the opposite hemisphere or the posterior fossa. Now, what's really fascinating here is the contrast between an SDE and your standard cerebral abscess. See, an abscess forms deep within the brain's substance, right? And the body reacts by building this nice protective fibrin and collagen capsule around it. SDE, on the other hand, forms between the membranes, so it completely lacks that tissue reaction and capsule formation. Because of this, and because antibiotic penetration into the subdural space is notoriously poor, SDE is a way more emergent, dangerous situation. Because it's so aggressive, if you don't manage it immediately, SDE can lead to some really severe secondary complications. Strangely enough, it can actually cause a secondary cerebral abscess, which we see in a staggering 20 to 25% of imaging studies for SDE patients. We're also talking about cortical venous thrombosis, which carries a massive risk of venous infarction, localized cerebritis, and it can even extend downward and become a spinal subdural empyema. Moving on to part two, epidemiology and demographics. Let's look at the data to see who is most affected by this and just how common it actually is. To give you a sense of the rarity here, the ratio of cerebral abscesses to subdural empyemas is 5-to-1. It is significantly less common. In fact, in one historical review of 10,000 autopsies, researchers found a grand total of only 32 cases of SDE. And when we look at the demographics of those affected, the data shows a very clear skew. The male-to-female ratio is notably 3-to-1, meaning men are literally 3 times more likely to develop this infection than women. Anatomically speaking, the vast majority of these infections, we're talking between 70 and 80%, happen right over the convexity of the brain. Only about 10 to 20% are situated deeper in the parafalcine region. All right, part 3, etiologies and origins. The crucial point here is understanding exactly where this infection starts before it ever reaches that subdural space. These infections rarely just appear out of nowhere. The infection typically reaches the intracranial compartment through the direct extension of a local nearby infection. It's actually very rarely the result of generalized septicemia. Instead, the bacteria kind of piggyback on the anatomy. They often spread through the valveless, diploic veins in the skull, frequently traveling right alongside an associated thrombophlebitis to reach the subdural space. Going point by point through the primary culprits, you can see paranasal sinusitis absolutely dominates the etiologies. It's responsible for 67 to 75% of cases, especially frontal sinusitis in adults. Otitis, usually chronic otitis media, comes in next at 14%. Then we see much smaller percentages for things like miscellaneous or undetermined causes at 7%, post-surgical neuro or ENT complications at 4%, trauma like compound fractures at 3%, and meningitis at 2%, which, by the way, tends to be a more common cause in pediatric patients. There's also a really fascinating historical shift worth noting here. Back in the pre-antibiotic era, chronic ear infections, otitis media, were actually the #1 cause of SDE. But today, especially in the United States, paranasal sinus disease, particularly involving the frontal sinus, has entirely surpassed it as the leading cause. Section 4, causative organisms. Knowing the specific origin leads us right into the specific microbiology involved. Because the bug heavily depends on where the infection started. For adult cases that specifically stem from sinusitis, which is the majority of them, aerobic streptococcus is the primary culprit. It accounts for about 30 to 50% of cases. This is followed up by microaerophilic and anaerobic strep at around 20%, and staphylococci at roughly 17%. However, if the subdural empyema is caused by trauma or a recent neurosurgery, the microbiological profile completely flips on its head. In those cases, Staph and gram-negative species absolutely dominate. It's really important to remember that Staph aureus is not a common pathogen if the STE came from sinusitis. And for childhood STE, the organisms generally just mirror whatever causes age-appropriate meningitis. Now, this next point is kind of wild. When doctors try to actually culture the bacteria from an STE, they get sterile cultures in up to 40% of cases. 40%! This massive rate of negative cultures is mostly due to the presence of fastidious anaerobes that are just notoriously hard to grow in a lab, or, because the patient was already exposed to antibiotics before the sample was even taken. And finally, Section 5, Clinical Presentation Findings. Let's see how all this underlying pathology actually presents clinically. Listen, if you take away just one single clinical pearl from this entire explainer, let it be this. You must highly suspect STE if you see a patient presenting with meningisms, that stiff neck and meningeal irritation, plus unilateral hemisphere dysfunction. That specific combination is a massive red flag. Let's look at the highest frequency findings point by point here. Almost every single patient, 95%, will spike a fever. Over 80% are going to complain of a severe headache, show nuchal rigidity, and present with hemiparesis. On top of that, roughly 76% will suffer from some form of altered mental status, and that's just due to the mass effect and general inflammatory involvement of the brain. Going further down the list, point by point, we see that about 44% of patients will experience seizures, and importantly, nearly half, 42%, will have localized sinus tenderness or swelling. That is a direct physical clue pointing right back to that primary sinusitis etiology we talked about earlier. Less common findings include nausea and vomiting, vision issues like homonymous hemianopsia, speech difficulties, and papilledema. I need to emphasize this for sure. Focal neurologic deficits and seizures are late-stage signs. If your patient is exhibiting hemiparesis or having a seizure, it means the infection has already significantly progressed. It's already causing severe mass effect or thrombophlebitis of the cerebral veins. Time is completely of the essence here. During a physical exam, point by point, you might also observe some very specific clues. You want to look for marked tenderness to percussion or pressure directly over the affected air sinuses. You might also notice localized forehead or eye swelling. And that facial swelling, it isn't just a coincidence. It's actually a direct result of emissary vein thrombosis, as the infection just wreaks havoc on the venous system. So because this infection faces absolutely zero anatomic barriers in the subdural space and naturally resists standard antibiotic penetration, early recognition is quite literally the only thing standing between a patient and catastrophic neurological spread. Knowing what you know now about its origins and early symptoms, what signs will you be looking out for first? Thanks for joining me on this explainer. Keep these points in mind and stay curious.